Hi, this is Brian Kim. I'm going to share with you this case of a patient who had a rotated Panoptix Toric IOL. The situation is the patient had a standard Toric IOL in the other eye, the first eye, and this is the second eye, and the patient was missing her near vision. And so we decided to put in a Panoptix Toric IOL in the second eye. But what's interesting is two things. Number one, the lens rotated even on post-op day one from 79 degrees to 30 degrees. And the patient was not happy with her quality of vision, either far, intermediate, or near. So this will be an IOL exchange of a rotated Panoptix Toric IOL at 6 weeks post-op. I'm going to try to figure out how did this rotate out of position and what did we do to fix it and prevent it from rotating again. So this is the primary case. You can see I skipped the earlier steps and now I'm doing the capsulorhexis. And I'm simply starting here because this is where I start to get an idea of what could be causing the problem and why did the lens rotate. And so I'm doing capsulorhexis. I don't see anything in particular that should make me worried. And then this is hydrodissection. So again, thus far, I didn't see any particular reason to be concerned about this patient. Throughout the case, including the capsulorhexis, I did not see appreciate any zonular stria or folds or anything unusual during capsulorhexis. And you know from my other videos, I pay a lot of attention to the capsulorhexis to give me an idea if there is some zonulopathy. And I didn't really notice any of those things. And so you see here, I'm disassembling the lens. Again, nothing particularly unusual about the case. Everything's going well. I'm performing the double chop and cross chop maneuvers. This is not a terribly dense lens, and I'm using mechanical fracturing techniques to crush the lens into smaller and smaller pieces. You can see the CDE is really pretty low. I'm able to very easily rotate the lens within the capsular bag. I'm not having difficulty. There's no stress on the zonules. And again, there's no evidence for zonulopathy. So again, I'm hooking the peripheral lens, crushing the lens into smaller pieces, using some vacuum to grab the lens pieces, and then crushing the pieces into smaller pieces, and then emulsifying the lens piece. Again, a fairly soft lens. I would characterize this as, around a 1+, maybe 1 to 2+, dense lens. Again, hooking the peripheral lens, crushing the lens between the instruments, and then emulsifying the lens pieces. And again, nothing unusual about this case at all. So this is the final lens piece. I'm getting underneath the capsule edge contra-incisionally, and then using some vacuum to grab the piece. Try to pull it up out of the bag, crushing it into smaller pieces, and then emulsifying the lens piece. Again, very methodical, slow, gentle removal of the lens. And then at this point, go ahead and take the chopper out. This is IA. Let's see if there's anything unusual during IA. Always start sub-incisionally to get a nice, clean removal of the cortex. Now here I start to notice that the bag is a little bit flimsy here. Can you tell? Posterior capsule is a little bit floppy. Yeah, you can definitely tell there's some floppiness to the posterior capsule. So again, now I do see that there's evidence of some zonulopathy, some weak zonules, but again, during capsulorhexis, it looked fine. Hydrodissection looked fine. Lens disassembly looked fine. But then during cortical removal, you start to see that looseness of the posterior capsule. As I'm peeling off the cortical material, from anterior to posterior, you can see that kind of loss of resistance. The posterior capsule was kind of pulling towards you with the vacuum as you're peeling the cortex. And so this patient does have some zonulopathy, and at this point, I don't really worry about zonulopathy when I do toric lenses. It's not typically something that I'm concerned about. And again, my experience with rotated toric lenses is very minimal. It's very rare for me to have that happen. And I've always attributed that to the fact that I'm able to deal with reverse pupillary block in those high myopes who have a higher tendency for the lens to rotate. But clearly, it's not just that, because this patient isn't a terrible, she is actually a myope. She's around a -3, -4 myope, but she's not one of those high myopes where you get the reverse pupillary block and the whole pupil becomes really huge and the chamber deepens. She doesn't have that kind of characteristic. You can see here I'm now just inflating the bag, and after I've cleaned up the bag completely, and I'm sweeping with the sweeper, polishing under the rexus edge on either side. And again, this is an insurance policy. People wonder and why we polish. This is the insurance policy that I do on every single case. And I think if you're going to do cataract surgery in this day and age, you really need to polish the capsule, because why? In this case, I ended up having to exchange the patient, and you're going to see the effect of that. You know, how easy or difficult is it to exchange a lens? Now, of course, this is only 6 weeks post-op, probably would have been fine if you didn't polish. But again, this is just good habits to develop. Polishing under the rexus edge, getting a nice clean bag so you don't have a giant Sommerings ring, you don't have a bunch of lens material stuck in the bag, which can fibrose to the lens. So I'm removing all the viscoelastic underneath the lens, polishing under the rexus edge, cleaning up the lens epithelial cells, and then I'll go ahead and remove the viscoelastic from the anterior chamber, and then I'll hydrate my incision. So again, a nice Panoptix toric lens. I'm going to set the axis at 79 degrees, okay, 79 degrees. And you've known from my other videos how I like to mark the patient. I mark the patient in the pre-op area, sitting up, and I have a axis marker. You can see it's very nice, thin marks. I'm using the axis ring to help me orient the lens. And then this is a Maltzman. I'm going to rotate the lens in position. You can see it's a little bit, maybe around 60 degrees or 50 degrees. So I'm able to rotate the lens counterclockwise, again, which is not the way Alcon advocates. Well, that's because they think, well, we're going against the current, we're going against the grain. That's not a good idea. But the fact is, as long as you keep the bag completely inflated, you can do that. Now, you shouldn't try to rotate the lens when the eye is collapsed. That makes no sense, because then you're just pulling on the zonules. But if the bag is completely inflated, there should be no contact of the peripheral haptics on the capsular fornix. And so now I've rotated the lens counterclockwise about 10-15 degrees, and now the lens is in perfect position, and it's at the 79-degree axis. I quickly push BSS, and I hydrate my incisions, make sure the lens is completely within the bag. And then, of course, I will double check as a final check the axis of the lens, perfectly well centered. Always have the patient look into the light and asking them to look at the 3 dots. I've had some patients tell me that it doesn't look like a light. And so when I said, look at the 3 lights, they were confused. So I just say, now look at the 3 dots. And so it's perfectly centered over the macula. You can see that the 3 dots are right over the central ring, and the lens is at the 79-degree axis. So you can see the lens is in this orientation, 79 degrees, and this is a patient postoperatively. She ended up minus 150 plus 3 at 91 degrees, which again made no sense. And of course, more importantly, post-op day 1, she was also miserable. She was 20/30. We hydrated the cornea and optimized the ocular surface, but she was very unhappy with her quality of vision at all phases, distance, intermediate, near. We also did a contact lens trial to make sure we neutralized all of her refractive error. And despite the contact lens trial, she still had about 20/30 vision at all distances. And so we concluded she cannot tolerate multifocality. Of course, we reminded her that she doesn't have a Panoptix in the other eye, and she got the Panoptix in the second eye because she wanted that near vision. Nonetheless, we both agreed that the lens needs to come out. This is her eye for her IOL exchange. You can see the axis is at 30 degrees. Again, this is not where I placed it originally, but it clearly rotated clockwise from 79 degrees to 30 degrees. So let's take a look here. I'm using a cotton tip to hold the eye, and I just use a cannula to just pop the incision open. Very important that you know where the incision is so you can apply that pressure on the external aspect of the wound, and I was able to pop it open very easily, again at 6 weeks post-op. And as you can see, the lens is actually prolapsing out of the bag as the chamber is collapsing. And so this is some dispersive viscoelastic. I'm asking the patient to look down, and now I'm looking for the left side incision. And the incision is right there. And how can I tell? I asked the patient to look down, and through the red reflex, I'm able to see the edge of the incision. So you go right over the incision, and I'm able to wiggle with the cannula, and then I'm able to gently pop through. And so again, this is not using any blades. You don't have to make any incisions. I made my paracentesis. I'm going into the bag with a dispersive viscoelastic, and I'm just trying to peel off the anterior capsule from the posterior capsule, visco-dissecting the capsules apart and going around 360 degrees to make sure I'm visco-dissecting the anterior and posterior capsule. This is the gentlest way to peel the anterior and posterior capsules from one another. And now here, look, I'm having the patient look up to the top of her head, and now you can see here, I can see the incision, the right side incision. And so now I'm going to place the cannula right over that incision, apply a little pressure, and I'm able to pop through. So again, I didn't have to make any new incisions. This patient is about 6 weeks post-op. I was able to open the incisions very easily, and then you saw as the chamber collapsed, the lens came out of the bag very easily. So no difficulty in getting this lens up so far. So again, I'm making sure the optic haptic junction right there is nice and loose, because why? That's where the adhesions tend to occur. You can see the lens is now able to move translationally in the bag. I'm putting a dollop of cohesive viscoelastic underneath the lens implant. I like to use cohesive here because the cohesive viscoelastic tends to stay round. And so I'm almost using it like a roller, and I'm able to use that mass to help visco-dissect the lens off the posterior capsule. And now this is a Lester. I'm just grabbing the edge of the lens and very easily and gently prolapsing the leading haptic out of the bag. And these gummy lenses are really nice because you can just grab it, lift it, and the haptic just bends in very easily. And I do the same thing with the trailing haptic. Just grab it at the optic haptic junction, and the trailing haptic just collapses and comes out of the bag as I lift it up. Now I have both haptics in the anterior chamber. Of course, you want to be mindful to protect the posterior capsule as well as protecting the cornea. And so this is a two-handed technique. The IOL holder is my left hand. The scissor is in the right hand. You can see with the teeth closed, I lift the optic up with the scissor. and then grabbing it with the holder in the left hand, cutting it, and as I go, I'm able to get a better grip in between. With the holder, you have to have that deep grip, the deep bite in order to get good control. And make sure I push the lens off the holder with the scissors, teeth closed, switching with the right hand with another forceps, using a two-handed technique to grab the tip of the haptic, pull it out of the incision, and then grabbing once again with the right hand, but protecting the cornea with my left hand. Pulling that piece out, grabbing the tip of the second lens piece, pulling it out with the right hand, but again, protecting the corneal endothelium with the left hand. So of course, if you just do the same thing again, very likely the same thing is going to happen again, and the lens will rotate. So you have to do something differently. So in this case, I'm placing a capsular retention ring. I like to keep the capsular retention ring within the holder there, and I'm just positioning it. You see that long rectangular groove. I'm able to place the CTR such that the left side eyelet is right over that groove, and then I'm able to place the injector with the hook pointed down, and you want to align the injector with that left side eyelet, and it goes in very nicely. So it's going to come out in a clockwise manner. Filling the capsular bag with more cohesive viscoelastic. You don't want any folds in the posterior capsule when you're doing this CTR placement. I'm using a Lester to lift the incision, and as the leading eyelet comes out, I hook the eyelet with the Lester. I'm able to dial in the CTR with minimal traction and stress on the zonules, and then I'm able to reposit that trailing eyelet into the bag by disengaging it with a Lester. This is the single piece acrylic toric lens. It's going into the bag. Going underneath the lens, lifting it, removing the viscoelastic from within the bag. Remember, there's a lot of dispersive viscoelastic in the bag. Very important to be mindful, removing all of that as much as you can. It's not going to come out in one big clump like the cohesive viscoelastic does at the end of cataract surgery. So it's very important to remove all that viscoelastic within the bag. And so you have to take a lot of time in doing IA when you're doing IOL exchange, in the bag IOL exchange. Polishing underneath the rexus edge, making sure I keep everything nice and clean, switching to visco mode, removing the viscoelastic from the anterior chamber. Checking the axis one more time. We're really close. We needed to nudge it just a little bit. It was more like at 70 degrees, so I nudged it a little bit with the Lester, doing some final IA. And when I'm done, I push BSS to prevent the chamber from collapsing and quickly hydrating the incisions. So again, placing a CTR makes a lot of sense, whether it's the bag is really big and floppy relative to the lens itself, it can rotate within that bag. And because it's opened up three-dimensionally, that's when the lens rotates. So by placing a CTR, you're putting the capsular bag on stretch, peripherally and circumferentially. And so by putting it on stretch, it's like taking like a pillowcase and pulling it on all four sides, and it makes it nice and two-dimensional. So essentially, if there's anything within that pillow, it will incarcerate whatever is in that pillow, because the top side and the bottom side of the sheets of the pillow will sandwich whatever's inside it. So the same principle with placing a CTR. By placing a CTR, you make the capsular bag, instead of three-dimensional, you're making it more two-dimensional. And if the lens is in the bag, it will collapse the two edges, the anterior and posterior capsules, toward each other and hopefully hold the lens into place. And so again, this is the lens position after the first surgery. I initially had it at 79 degrees and then it ended up at 30 degrees. Again, quite a bit of clockwise rotation, and then this is at the end of the IOL exchange, back at 79 degrees. And so this patient initially had a rotated lens, a -150 +3 at 91 degrees, and had an unhappy Panoptix toric lens. And post-op day 1 after the IOL exchange, the patient had 20/20 uncorrected distance vision, and she was happy. So again, this is a patient who had a rotated Panoptix toric IOL post-op day 1, zonulopathy, presumably a floppy, loose bag, which rotated clockwise. I placed a CTR, which will allow the capsular bag, instead of having a big three-dimensional configuration, by tinting it peripherally, like you're grabbing 4 sides of a pillow and pulling out, and you're keeping the 2 sides nice and tight in contact with each other. Same principle, this causes the anterior and posterior capsules to be tight against each other. And because the lens is between the anterior and posterior capsules, it catches it and holds it into place, and it reduces the risk for IOL rotation, and this patient was happy. So I hope this was helpful to you, and I thank you for your attention.